You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. Today, I sit down with Dr. Matt Denenberg, Chief of Pediatrics at Corewell Health East. We discuss the realities of physician leadership, building unified health systems without enforcing sameness, and the transformation brought by EHRs and clinical communication tools. We also tackle peer review, disruptive provider resolution, disaster readiness, and the complexities of adolescent access to health records. If you're a healthcare executive or physician leader who's tired of buzzwords and wants pragmatic, sometimes contrarian insights on systemness, quality, disruptive docs, and disaster readiness, this conversation is for you. Let's plug in. Dr. Matthew Denenberg, where do we find you this morning, sir?
I am in my office here in Royal Oak at William Beaumont University Hospital in Michigan.
And that used to be William Beaumont Hospital, I believe.
Used to be William Beaumont Hospital when I was born here in the 60s.
I was going to try to one-up that. I was not born at that hospital, but I did get some sutures in my head when something fell on my head when I was like 4 or 5 years old at that hospital. So I do feel a connection to you and to that hospital system. Well, I should welcome you to our podcast, and I'm going to ask you to kind of give us a little introduction to yourself. How did you get into this position that you're in now? What is the position that you're in now?
Yeah, it's funny. The residents and students that I mentor ask me that all the time because everybody believes they want to get into hospital administration, right? So I have a pretty traditional pathway. I started in college and went to medical school, and then I did my residency at Bellevue, spent a year in New York at Bellevue, and then did a combined pediatric emergency medicine and emergency medicine program at Detroit Medical Center at Children's Hospital, Michigan, where you and I met as residents.
That's right.
Was finished up school and was ready to go out and save the world. And so I took a job as a pediatric ER physician and a general ER physician in Fairbanks, Alaska. Went off to the Great White North where it was 40 below in the winter and 60 and sunny in the summer. And after 2 years of that, my fiance, my wife now of almost 25 years, said, I'm not going to Alaska. It's 40 below and dark. So we came back to Michigan, and I took a job at Helen DeVos Children's Hospital, which wasn't Helen DeVos Children's Hospital at the time, but in early 2000s, and as a pediatric emergency physician, just started clinically, and then got asked to do things, right? Do you want to work on guidelines? Do you want to work on protocols? Do you want to work on making triage better for kids? Do you want to develop a department? Hey, by the way, we're going to build this 13-story hospital. Do you want to design a trauma center? You want to be the first CMO, and you know where this goes, right? So just slowly through time, took on bigger and bigger roles as a physician leader. And now I've crossed over the state as we merged with Beaumont and Spectrum Health 3 years ago. I'm now the chief and chair of pediatrics here at Corewell Health East, which was Beaumont Hospital in the past.
All of this is impressive, but even more so, given the fact, and I believe you will agree with me, that we both graduated from residency about 5 or 6 years ago. And so that's my story, and I hope you support it. That's a long process. So it sounds like mostly you were given a task and you succeeded at that task. And they said, well, if you can do that, let's try something else.
Yeah, it's interesting. You have two ways of some folks get into leadership nowadays. They get their MBA, they get their degree right out of school, they get into leadership, and others just kind of kept asking to do things. And when you're able to just get stuff done, people keep asking to do bigger and bigger things. And that's kind of how my 22 years in leadership has progressed, is just continue to do bigger and bigger things and get more done and asked to take on bigger roles. I have a very different approach as a lifetime learner. I didn't go on to get my master's in ethics or my MHA or my master's in quality and safety to pad a CV or to have more letters behind my name. I did it usually at points in my career where I wanted to continue to learn and learn things that I could use every day. So, I took on a master's in ethics at Michigan State University at a time when we were just getting started on our ethics committee work and some of the work I was doing in pediatrics and pediatric consent and some other things. And so rather than the traditional, go to a course, go to a podcast, we didn't have podcasts back then, get CME, I decided I'm going to spend the time and effort to read a couple dozen books and might as well write some papers and talk to some college professors and get a degree out of it. And so that's kind of how I looked at my advanced degrees, as there were ways to advance my career and my understanding of medicine and pediatrics and how to take better care of our health system.
Let me play off that last word you just said, health systems. One of the things that seems to be a defining part of your career is kind of building systemness, taking a bunch of disparate either departments or organizations and bringing them together. So, tell us, what have you done in that area and how do you kind of think of systemness and what are the benefits?
I've been lucky, right? Because if you looked at when you and I started, we didn't have these big systems. We had hospitals. And I think that some of the success you see in the building systemness that I've had, systemness is built around me, right? We started as one or two hospitals and then we started growing as systems. And so the idea of bringing folks along, right? Bringing folks into understanding that systemness isn't sameness, right? We want to unify how we take care of patients. We want to unify how we take care of the community. One of the reasons for hospitals coming together as systems is to provide higher quality, more affordable care across a region. And without systemness, it's disparate and it's choppy. And so systemness to me is bringing really good folks together, nurses, docs, administrators, everybody together to provide better care for everybody across the system. And I'll use a cliche. We want folks to understand, to have the same kind of care, whichever door of the system they come into, whether it's in the northern rural system or in the urban part of the system. And I think that, to me, that's what systemness is. It's not sameness. It's unifying how we care for patients in the community.
How do you design that? We like to talk about design on this podcast series. Is that something that you think about from the beginning, or does it move along as you are adding groups and trying to put things together in a way that they, the whole is greater than the sum of the parts?
There's two ways, and the second one is more successful, that health systems do systemness. One is they come in and they say, here's the structure, here's the policies, here's how we're going to do it. Everybody adopt. Go, you have to do it. That never works. If it works, it takes a decade. The other way is you really have to have some governance, structure, culture, and really some incentives behind getting people to do the work together. So if you just standardize across hospitals without engagement, it's not going to work. And so to me, and I said this before, systemness is not sameness. You really do need to get folks working together, and it's layered on trust, right? Remember, hospitals are traditional systems with ways of doing things. You have to convince people that doing it together is better. And to your point, it is better. You just can't force it. And you can't force really smart people and really dedicated people to do stuff. And so the best way to do it is bring them along. And that's how we did it, right? We failed the first time. Don't get me wrong. We failed the first time because we tried to force systemness. And then we took a step back and said, all right, let's get everybody in a room together, stakeholders together, and let's get a common goal.
When your doctors and nurses and therapists can see the benefits of, they now have access to resources they didn't have access to before, or technology that they didn't have before, their jobs become easier. And what they're usually looking to do in the clinical side is care for people and for kids. And so, yeah, that makes sense. I've always tried the first method, which is just telling people what to do. Well, so some of your experience has been, as you build this systemness, is around technology. There's
two times in my career where technology has been more than just a tool, and I was involved. They were transformational. One is the EHR. There's no question. And I can say the EHR, and for those physicians on the line that are listening to this, they're probably throwing things at me, but the EHR was one of them. Because I remember as a student in the ER in Chicago doing records on triplicates. And then I remember when I started at Spectrum having charts stacked as high as the desk to try and find an EKG for a patient that was in the middle of having an MI in our ED, and then having a dumbwaiter bring me, and I'm not talking about a person, a dumbwaiter from the basement, bring me charts. And so bringing Cerner online, or bringing Epic across a system, or bringing a bridge forward, all of these new technologies, they added to that platform. So the EHR has been transformation. So my involvement as a physician leader has been to bring people along, right? To convince them of the need for the change, to help them understand why we're doing it, and then to help them with the technology, right? I was part of those teams that helped bring the EHR forward from paper to the EHR. You and I did that together at Detroit Medical Center when we were younger, but then from various formations over the last 22 years. And then the second piece, again, is another transformation or foundational piece is clinical communication. If we can't talk to each other, if we can't have in the moment, real time conversations, especially when we're taking care of acutely ill patients or staff members that are having an acute issue with security or whatever the issue is, if you can't communicate in real time, or effectively, it dies. So I've been very involved as we brought clinical communication tools forward so team members could talk. And when I say team members, I mean everywhere from environmental services and food services all the way up to the CEO of the hospital is engaged in these systems. And so the ability, the first system I helped bring online was a communication tool called Volt, where I think we were doing 10 million messages a month or a year, 10 million messages a year. And so that's a lot of communication. And if you don't have a tool and technology to get that right, it's a mess. And so those are the two big projects that I'm most proud of. I mean, other things along the way, obviously, but those are the big ones.
Yeah. Well, you certainly are not going to get any disagreement from me about the transformation of the EHR. And I agree. Many physicians, they'll tell you they're unhappy. And then but you always can go to them and say, well, should we go back to paper? And the answer is invariably no. All I want you to do is fix this aspect or fix that aspect of it for me. And we've come a long way from the days 15 years ago or so where we were kind of just throwing these things in and hoping for the best to now there's implementation science. And who knew that it could be science? I just thought it was we turn on the application and hope for the best. So we've gone from too little information. I remember as a resident with you going down to medical records and trying to find, right, in the middle of the night. It was 3 a.m. And if we didn't have a medical student, we went down ourselves to try to find old records so that we could. And then it was sometimes huge amounts of records to try to get through. Now we have the opposite problem often is too much information.
Well, and I'm not sure that's completely an EHR issue. That's a data issue. I mean, we concentrated on as physicians and caregivers because we live that every day. But I got to tell you, my email is full of data that I'm not interested in. My social media stuff's full of data that I'm not. So it's, for me to get through my email now, my personal email takes me an extra half hour every 2 or 3 days because of all the data and junk that's thrown at me. So I'm not sure it's just the EHR. We are getting better. This EHR, the data science that you guys are implementing, the experts that are at this, it's making a difference, but it's everywhere. It's not just the EHR. It's everything that uses data now. It's just too much. And if a non-ER physician wants to spend more time dictating or writing a super long note, first of all, I want to teach them not to do that because we don't need these long notes with everything pulled in. But if they want to do that as an ER doc, I'm hoping to use AI to just go through their bloated chart and just give me the information I need to take care of that patient in the moment. And hopefully they'll stop doing that someday. But at least there's a fix for that with AI because some people you won't be able to stop doing that. But I got to tell you, as an ER doc, I don't need to read a 10-page note to get to what I need. I need AI to tell me, here's the 5 things you need to know about Jimmy that's in front of you to take care of his shunt in the moment.
We write notes. Well, I'm not even sure we're going to continue to write notes, but we write notes for many audiences. One, of course, ourselves, our future self, and for our colleagues, and for our defense attorneys and our QA people and our billing folks. Lots of different reasons to write those notes. I remember practicing in Michigan. This is long before I had an electronic health record, but I would get from my ENT friends when I sent patients, hey, should this patient maybe have tubes? And I would get a 3-page letter, very nicely typed. And I instantly, I think like every primary care physician, would just go to the final page and where it said assessment and plan. That's all I cared about, which is one of those, changing from a SOAP note to an APSO note, putting the assessment and plan at the top, especially with electronic health records, just makes complete sense because most of the time that's what we care about. There's absolutely times where you're interested in their physical exam finding or something, but 90% of the time, all I really, if I'm asking you for your opinion, is I'm interested in what is the What's the bottom line, and what are you going to do about it, or what do you need me to do about it?
I think this helps our coders and billers because rather than having to search through all of our writing or all of our dictations, they are going to be able to say, what code should this be? And the AI is going to figure it out because they're going to search everything. And the same thing with the payers. I think the payers are going to win because the payers are telling us, we're going to get rid of pre-authorization. No, you're not. You're just going to use AI to do the same level of scrutiny. You're just going to say, should we approve this or not? And AI is going to decide because you're not going to be searching the entire record. And so I think patients will win eventually because things will be quicker. But I think that ability to search through data quicker and get to the same or better answers where we're all going to win.
Let's pivot a little bit. At the organizations that you've been at, you've had responsibility for quality or peer review, making sure that physicians are practicing the way that they should. Has that been something that you relished, or was that foisted upon you? If it were me and someone said, I need you to judge some of your peer physicians and tell them if they're not doing a good job, that would be not high on my list of stuff to do.
I would say as a physician leader, it's all of our job to make sure that our peers and our colleagues and those that we're responsible for are not only practicing in a way that's safe, high quality, and good experience for the patients, but more importantly, that we're helping them have a successful career. And that's really my peer review. The peer review we've done is one of my proudest moments. You know, we both grew up in an era where peer review and M&M were let's see how much we can shame this provider. Let's see if we can find everything they did wrong as a Monday morning quarterback. And then if they can leave the room without crying, maybe it's okay. But if they cry, that's probably okay too. And so that sort of shame and blame culture has been pervasive. And so we took an approach to really start working on that organizational learning aspect. We wanted peer review to be an opportunity for our peers, our friends, our peers to improve. So if somebody does something, God forbid, that causes harm, or does something that's not according to policy, or does something that's not exactly best practice, most of the time they're not doing it on purpose. They're not doing it to be harmful. So we have to find a way to help them. And more importantly, they're probably doing something that somebody else in the same position would more than likely or likely do the same thing. So we take an approach where we developed an organizational learning peer review. We all learn from all of the cases. Now, don't get me wrong. If someone does something totally out of scope, they have no business doing, or totally against policy, there are actions for that. But what I found in doing this for 5 or 6 years now is most of the things that most of the physicians do, a lot of us look back and be like, in the same circumstances, I could see how I would have done the same thing. You know, Monday morning, I could say I wouldn't have. And so we took an approach where we want that person to learn as close to the event so they don't do it again. We want everybody else to learn so they don't do it for the first time. And then we want the system to learn, boy, we set them up for failure because we didn't have these 5 things in place. And so it's the organizational learning for the person, and it's the system learning for the system. And I think we've made some really good strides in sepsis care. We've made some strides. Physicians that in the old days would have waited to 5 or 6 bad cases and they would have been in trouble. So we catch them with the first case and then we all learn from it.
I love the idea of, hey, how do we make it not only easy to do the right thing, right? First thing we have to do is define what the right thing is, and then create systems and to make it easy to do that. But also, how do we make it, if we can't often, but if we can, how do we make it impossible to do the wrong thing? Kind of an adjacent topic, looking through your CV, you list disruptive provider resolution as an area of expertise. Part of your leadership, so we talked about kind of quality and making sure that patients are safe and trying to improve the care that we give. And oftentimes that is improving the care that not just that other doctor gave, but that I'm going to do tomorrow. I want to make sure I do it right. Disruptive doctors. I recall as a medical student at your institution, Dr. Denenberg, watching a surgeon throw a tray of instruments at the wall, kind of screamed at the resident, "You're killing the patient, you're killing the patient." Now, he was not killing the patient, but it wasn't really accepted even back then, but nothing happened to that doctor that I knew of. And I think nowadays something that behavior would have resulted in potentially coming across your desk. And so is that still a problem, by the way, or have we kind of matured beyond that?
It's still a problem. And I'm really careful. And I've done this before. You know, obviously we like to use the surgeon analogy, but I got to tell you, over doing this for 20 some years. Pediatricians are just as disruptive. And you know this, surgeons are disruptive, hospice care doctors, everybody. I have learned a ton from some experts in the field. There's 2 or 3 different kinds of disruptive positions. There's the kind that you describe where there's a red line. There are some red line issues. You cannot throw a scalpel. You cannot yell and scream and swear at a patient and a nurse and a tech because you're angry that they didn't, do exactly what you wanted. Those are just human decencies that we have to and have not done a very good job traditionally and are getting better at it. But then there's the piece of disruption that I think we needed to start in medical school. I'm on the SPRC committee, which is for disruptive medical systems, but for students with behavior issues. And I got to tell you, we got to start with early intervention and early coaching because we are highly educated, highly competitive professionals that are in high acuity business. And I don't think we give ourselves enough credit early on in our careers to prevent disruptive behavior. So I think one of the things that I think that I've become pretty good at, and I've helped our teams become good at, is there are all kinds of reasons why people are being disruptive. And I think we got to find a way to help them through that, right? I'm not saying people get 10 chances, but I've had providers have had substance abuse issues that we've been able to successfully get back into their careers. I've had providers that have been going through family issues. We've had providers that have had, medical issues that they weren't sharing. There's all kinds of reasons why physicians are disruptive, and it's on us as peers and as professionals and as leaders to figure out ways to prevent that if we can. There will always be times when we just have to take action as a medical staff. I get that, but that's few and far between. The number of providers we've had to terminate or kick off staff, I can count on one hand. The number of providers we've helped through with coaching, I can count on many, many hands.
So as you mentioned, you did a residency in pediatrics and emergency medicine. From the emergency medicine perspective, you've done some work as a medical director for FEMA and worked on pandemics. What have you learned from that aspect? Most of us, when I think about your pediatric hat, that's far from stuff that most primary care pediatricians for sure would have to deal with. What about that kind of work excites you or piques your interest?
I'll start out by saying it's pretty clear, and the evidence supports that we are not in this country, and I think COVID showed us this, we are not ready for a significant disaster and or major event in healthcare, adult and pediatrics. We're getting better, but we just don't have the interconnectivity among highly competitive health systems, even though health systems are getting bigger. And so if you take that non-readiness and emergency preparedness for healthcare, magnify that by 10 for pediatrics. We just have not for decades been as prepared. And we know that, right? We did our first survey in 2016. Pretty clear we aren't ready. We did another survey a couple years ago, better, but still not ready. And so I've been very involved with a couple of grants, one through HRSA and one through ASPR with children's hospitals around the country as we start to prepare a preparedness network, preparedness protocols and ideas and language around how children's hospitals and health systems that aren't children's hospitals prepare for a surge or a disaster. And so that's been a lot of fun, but we got a long way to go. We're making progress. We are definitely making progress. But this is the first time I feel optimistic. There's 2 major networks right now that bring about 20 or 25 of the children's hospitals from Puerto Rico all the way up to Seattle, Washington, that are finally creating these networks of readiness. And I think as long as the federal government and the state governments continue to support that work, I think we're moving in the right direction.
I'm hearing that you don't believe that children are just small adults.
No, and I'll tell you something funny. When I was in one of my previous roles with my background in emergency medicine, I used to also give a lecture for the pediatric residents that adults aren't just big children. There are, when you work in a pediatric emergency room and grandma has a stroke in front of you, all of the peds ER docs get nervous, like call 911, get them over to the adult hospital. So those of us that are adult trained are like, wait a minute, we'll stabilize them. I'm kind of kidding, but I'm not. So yes, and especially in pediatrics, they are not just small adults. physiology is different, medicines are different, their development's different. One of the things that we believe that we were ready for pediatric disasters is, we'll just bring in all the equipment and we'll just take care of them and we'll bandage them up or we'll take them to the ORs. I'm like, okay, but don't forget the developmental needs of those kids. A 12-year-old, a 10-year-old, a 6-year-old is not the same as a 24-year-old. And don't forget the family reunification piece. What are you going to do with all those kids that have been separated from their families? It's, a 19-year-old can figure their way out. A 6-year-old can't. And so I think they are not just small adults. No.
You've been involved in figuring out how adolescents can access technologies such as the electronic health record. How does that work? How adolescents are, I don't know if you're sitting down. They're difficult. They're difficult. You might want to sit down for that comment. How have you been successful in kind of dealing with adolescents' access to technology like the EHR?
So if any of my detractors from this work are listening to me, you're gonna love this statement. When we started doing this work, my 19-year-old college student and my 17 soon to be 18-year-old daughter were not adolescents. And so I was doing this out of my knowledge as a pediatrician and my research work in adolescent ethics. But I got to tell you, the hardest part about figuring out how to give adolescents or allow adolescents appropriate access to their healthcare records and to their healthcare in general there's 3 or 4 things that complicate it. One is that family dynamic. There is this dynamic between the parents and the adolescent. They are struggling with trying to figure out, how's my child going to become an adult? So during adolescence, parents have different views. Some believe that their adolescents should have full access to their medical records and be able to make decisions. And others are, until you're out of my house or until you're 18, I'm making all the decisions. I need to know everything. So you have those, and it's different in different parts of the country, right? The other piece is the legal aspects. Every state has a little bit different laws. Some adolescents get a little more rights at 13. Some get it at 12. Some get it at 14. Some don't get it till whenever. So you got to deal with the legal and compliance piece of it. And then there's the public piece of this, right? What does the public want you to do? And then the last piece is the payers. Even if we make it so that adolescent has full access to the record and the parents don't have access, the payers still send a bill to the parents for that pregnancy test in that 15-year-old. And so we had to take all of that mess that nobody really needed to deal with in the paper records because it was a little easier. You just didn't write in the record when you didn't need to. Parents had to get a copy. The electronic record is more difficult. So we set up a system. We worked with Epic. We worked with the Epic builders, and we built a system where at the ages of legality in Michigan, we were able to turn on the adolescents' access to their own chart. We were able to give parents the appropriate limited access to help them make appointments and stuff. But if it was a child with complex medical needs or some reason why the primary care pediatrician felt the parent needed full access, or the child agreed to it, the adolescent agreed to it, we gave that kind of access. So we developed three kinds of access. And it was hard at first, but Epic really did a nice job of helping us sort that out. So we did that live on the west side of the state, and then we brought it to the west side of the state when we switched to one version of Epic last year. So, of course, you can imagine, Greg, you know it. The parent concerns I got about, what do you mean my child has access? What do you mean I don't have access? But in the end, it's the right thing to do, right? Our kids need to become adults. The key to all of it was, and I will give Epic some kudos on this, is they really helped us fine tune what we were doing in the state of Michigan, who's got some very specific laws and rules around this. But then when we presented it at UGM, we had other states reach out to us and adopt the technology, the methodology behind it. So like a lot of what we do in pediatrics, especially adolescents, it's a leadership issue. I needed to know, and I had the support of my leaders, that when they got a call from parent X yelling and screaming, or they got a call from Congressman Y, that they were going to support that we were doing the right thing.
Absolutely. Without that leadership support, you're useless. And from a designing perspective, I think that's a really important point, right? To kind of help leaders saying like, hey, it's not a possibility that someone's going to call and complain to you. It's definitely going to happen. And so let's think about tell me what you're going to say to that parent or to that congressman. This was an amazing conversation, Dr. Denenberg. We like to always end these talks asking you a design question. And the design question is this: is there something in your personal life or work life that's so well designed that you it makes you happy every time you interact with it?
My wife would say that my work-life balance design is terrible. But again, she's been very supportive of all the work too. I'm going to tie this all together with one thing that if I chose to retire tomorrow, the one piece of work that I've been involved in the last 10 years that I'm most proud of is our help chain work. And it really was a modernization of the chain of command, which is a term I don't particularly like. And if you look at some of the stuff that we talked about this last 45 minutes, the foundational pieces of clinical communication, of organizational learning, right? Getting providers to work together to solve problems for patients. The idea that we want to flatten the hierarchy and not have these authority gradients. We created a help chain which uses all of these tools. And if a nurse or an environmental services or a physician is having an issue in the moment with patient care or patient safety or provider or team member safety, if it's urgent, we use our normal process, Code Blue, RAP, whatever you want to call them. If it's something that clearly can wait till tomorrow, that parking lot needs to be repainted, fine. But if it's a patient that needs pain medication or needs something urgent for their care, and let's take an example, a nurse is having a hard time getting a hold of the physician. We wanted to make sure that we had a help chain so that after 20 minutes of trying to get hold of the first person in line, use the help chain. So the next escalation is a manager. And if not, the third escalation line of that help chain is the physician executive on call. So we had a group of 4 or 5 of us that promised we would be nice no matter what time of day. We promised we would help find the solution. We didn't have all the answers, but we knew, to your point, how to get a hold of who around the system. And so there was always somebody at a level to help that person take care of a patient. So we universalized that on the west side of the state. And now the help chain is universal across the system. And that's my proudest piece of work because it's allowed nurses and team members to have immediate access to somebody to help them get something done when they feel they weren't. So I got tired of hearing in the morning, boy, we tried to get hold of Dr. X for 7 hours for pain medicine and they never answered. And so I think that's my proudest piece. I think that is the design that I think is the thing I'm most proud of.
I love it. It's simple and straightforward, yet incredibly effective.
Simple, straightforward, effective. You know what? We want things that are simple and elegant, but it's not complicated.
Right. Dr. Denenberg, thank you so much. This has been a great conversation. I certainly learned a bunch. Thank you, sir.
Awesome. Thank you.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Dr. Denenberg, check him out on LinkedIn. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.